Hi, I'm Dr. Amrit from Neurosurgery. I'm here today to introduce you all. Firstly, good morning, and it's my absolute pleasure to introduce our speaker today, Dr. Lee Kim Peng. So, Dr. Lee Kim Peng is a senior lecturer and neurosurgeon who recently joined us at University of Malaya. He graduated from USM with his master's in neurosurgery. He was in HKL, and currently he has decided to join us. Today he'll be talking about lesions involving pineal glands. And please join me to welcome Dr. Lee Kim Peng for his talk today.
Hi, a very good morning to all, and thank you for the opportunity. Thank you, Mr. Amrit, for the kind introduction. Okay, so my name is Dr. Lee Kim Peng, and I recently joined the Department of Surgery, Faculty of Medicine, University Malaya. Okay, so today the title of my talk is From Third Eye to Microsurgery, the Pineal Gland Across History and also Modern Era. So basically, I'll be taking you on a journey to one of the most fascinating structures in the human brain, which is the pineal gland, moving on from talks regarding ancient myths and also philosophy to anatomy and pathology, and ultimately moving to modern microsurgery. Okay, so to begin with, for thousands of years, humans have searched for the seat of the soul. And by asking where is the seat of the soul, we are asking where does our consciousness arise, where does our identity and our life itself reside in our body. So different cultures and different civilizations have proposed different answers from the heart, the brain, and interestingly, some of the ancient civilizations proposed that the existence of this pineal gland and that it is the seat of the soul. Okay, so why has the pineal gland fascinated humanity since time immemorial? It is because ancient civilizations, particularly the Hindu, Buddhist, and even Egyptian civilization, associated with higher consciousness, spirituality, and even enlightenment. And there's one a French philosopher named René Descartes in the 17th century mentioned pineal gland as a seat of the soul, which means it is the main point of contact between our body and our soul. Okay, so moving on to the concept of the third eye, it is a popular concept in the Buddhist, Hindu, and even Egyptian civilization. So basically, the third eye concept symbolizes a metaphorical inner eye that, when activated through spiritual practices like prayers and even meditation, can lead to profound levels of consciousness, spiritual awakening, wisdom, and ability to see beyond normal, ordinary human perception. So interestingly, as we can see in this diagram, there's a statue of Lord Shiva as well as the Buddha. It can be seen that there's a presence of a third eye in the middle of the forehead above the eyebrow. And it has been found that this location roughly correlates with the location of the pineal gland, which is rather fascinating. And in the diagram on the right side here, it shows the 7 Hindu chakras, which are the energy centers of the brain, of the body, and pineal gland has been proposed to be one of it. And in the diagram on the right lower corner, we can see an Egyptian diagram, which is called the Eye of Horus. Okay, so this diagram here, okay, can you see my pointer? So this is the diagram of Egyptian Eye of Horus, which is an ancient Egyptian symbol of protection, prosperity, and also healing. And this diagram was found to have striking resemblance to the anatomy that we know now, which is the pineal gland, as well as the thalamus and the midbrain. And it is rather fascinating because the ancient civilization are able to propose the existence of such gland when the anatomical knowledge is rather limited. So this reflects the human's long-standing curiosity about human consciousness itself. Okay, so now moving on to modern neuroscience. So what do we know now regarding the pineal gland? The term pineal gland originates from pinea in Latin, which means pine cone after its appearance. The shape is like a pine cone. So it is a small midline unpaired neuroendocrine gland, which is located at the posterior aspect of the third ventricle, and it is very small. It measures 5 to 9 millimeters in size. So imagine it is that small, and it is very deep-seated in the center of the brain. Okay, so what makes surgical access to this region challenging is that it is very deep-seated, and it is located surrounded by many vital brain structures such as the thalamus, the brainstem, and even the corpus callosum, as well as many deep cerebral draining veins here, as well as the CSF pathways such as the third ventricle and the cerebral aqueduct. Okay, so what do we know now regarding the function of pineal gland? So definitely the function is not as a third eye. So modern neuroscience mentions that pineal gland, the main function is to secrete melatonin. Okay, so basically it is a hormone that's important in maintaining sleep-wake cycle and circadian rhythm, basically our biological clock. It has also functions to regulate our hormonal cycles as well as puberty timing. So basically there are some authors that mention that pineal gland is the master of our biological orchestra. Okay, so this gland is very tiny and it has an important function in modulating our biological rhythm. So what can go wrong with this gland? As you can see from this diagram from the various MRI and also CT scans, tumors, aneurysm, vascular pathologies, and even benign cysts can arise from this small gland. Okay, so this is the diagram showing a classification of the pineal tumor. So as you can see, the spectrum of pathology can arise from this gland is rather broad, from germ cell tumors to pineal parenchyma tumors to other tumors such as esophageoma, ependymoma, meningioma, etc. And each of the tumors have different grades of aggressiveness, different prognosis, and different ways of management. Okay, so when things go wrong, how do patients usually present? They usually present with headache, vomiting, visual disturbances, and because of its location in proximity to the CSF pathway can get blocked easily, leading to hydrocephalus and reduced level of consciousness, which requires urgent neurosurgical intervention, that is to divert the CSF, followed by addressing this lesion. Okay, so on this diagram on the right side here, there's a characteristic syndrome that is associated with pineal gland lesions, which is called the Peyronie's syndrome. So basically, it is a tetrad of upward gaze palsy, right near dissociation, convergence, retraction, nystagmus, and lip retraction, also called Colliers sign. Okay, so how do we manage pineal tumors? Okay, this is just a simplified diagram of a management of pineal tumors. Of course, it's more complicated, but basically, when a patient presents with symptoms, urgent diagnosis is required via neuroimaging by performing CT brain and MRI brain plus spine, and also routine blood investigations as well as tumor markers such as the beta-HCG, alpha-fetoprotein, and placental alkaline phosphatase, because as we know, part of the pathology includes germ cell tumors. So if a patient presents with acute hydrocephalus, they require urgent CSF diversion, for which can be either external ventricular drain, VP shunt, endoscopic third ventriculostomy, followed by biopsy, which can be done either endoscopically or stereotactically, followed by definitive management such as surgical excision, chemotherapy, and radiotherapy. Okay, so next, moving on to our further talk, will be focusing regarding surgical excision. So how do we reach the pineal gland safely? So given that this gland is deep-seated and it is close to many vital structures, as we mentioned, such as the corpus callosum, the midbrain, and even the thalamus, and injury to these structures is very unforgiving. Patients might not wake up. It is also close to many deep cerebral draining veins, as you can see in this diagram on the left lower corner here. The vein of Galen and also the internal cerebrum is located adjacent to this gland, and it is also located very close to our CSF pathways such as the cerebral aqueduct and also the posterior third ventricle. So the strategies that we have now includes endoscopic and also microscopic procedures. So endoscopically is what we can show in the diagram A here. So it's entered from anteriorly, whereas from posteriorly, posterior superiorly, posterior and posterior inferiorly, we have many other approaches that can be assessed via microscopically, okay, via microsurgery. So just to illustrate a few examples, this is the example of a endoscopy to pineal region tumor. So you can see that the patient is being positioned supine with a burr hole that is done anteriorly here. Okay, so after a burr hole, the surgical endoscope is being introduced. Okay, so a trajectory is marked to the floor of the third ventricle to perform a stoma in order to aid CSF diversion, and the scope can be redirected posteriorly to the pineal region where the tumor is for biopsy. Okay, so just to illustrate an example, so surgical endoscope is introduced from the lateral to the third ventricle. The floor of the third ventricle is identified and a stoma is done, an opening is done to aid CSF diversion. And then after that, the scope is redirected posteriorly we can see fluffy tumor here, and multiple biopsies are taken. Hemostasis is secured, followed by closure. Okay, so the next approach that is done is open microsurgery via, this is an example of what we call supracerebellar infratentorial approach. So a patient is being placed in prone position, or it can be done in sitting position. Then a posterior fossa craniotomy is done. Dura is open, cerebellum is exposed. Then subsequently, as we can see from this diagram here, the cerebellar retraction is done to open up the supracerebellar corridor, followed by deeper dissection, followed by arytenoid opening. And after this arytenoid opening, we can see the pineal region, and we can see that it is located very close to superiorly to a draining vein, which is the vein of Galen. Tumor capsule is open, tumor is excised, and complete tumor excision is achieved when we can see CSF gush, because the anterior limit is posterior third ventricle, followed by hemostasis and closure. Okay, so given that there are many surgical approaches to this region, what are the factors that make us surgeons decide which is the best factor for each patient? Of course, it has to be individualized based on the location and the anatomical extension, whether it's anterior, posterior, superiorly extending. Depending on the venous anatomy, which is deep venous system anatomy, as well as the angle of the tentorium, depends on the suspected pathology, depending on patient's clinical presentation, neuroimaging, the patient profile, and tumor markers. Because as we know, younger patients, they tend to have germ cell tumors, and some of it tend to be chemo and radio resistant. So biopsy rather than full resection is required. Surgeon preference and local facility, as well as hydrocephalus. Okay, so just to illustrate a case example of a patient's journey that I had the privilege of being involved in my previous center in HKL. This is a 62-year-old lady who presented with acute onset headache as well as hydrocephalus. And by the time she presented, she was already bedbound, and neuroimaging shows a huge pineal region tumor. So urgent ventricular peritoneal shunt is done, followed by microsurgery via a supracerebellar infratentorial approach. And as we can see, we were able to achieve complete excision, and subsequently, post-operatively, the patient was able to return to normal life. So this represents the reward of precise neurosurgery. It has high stakes, but it has also the ability to restore patients' neurological function and also quality of life. However, despite all success stories, not every patient's journey is perfect. Some patients might experience some complications, and some of it can be disastrous. So the complications include venous injury, which can lead to venous infarct in the deep structures of the brain, which can lead to poor outcome. Venous injury can also lead to torrential hemorrhages. Patients can also develop cerebellar swelling, cerebellar infarct, and even cerebellar bleeds. And the worst of all is a brainstem injury, which can lead to brainstem hemorrhage and also infarct. And all these complications can be disastrous, leading to poor outcome. So despite all the success stories, this reminds us the limits of human intervention and the importance of humility, precision, patience, and teamwork to ensure good outcome for the patient. Okay, so given that there's so many surgical risks which are involved in a surgery to this deep-seated structure, what are the various strategies that have been taken to improve the surgical access and outcome and to elevate the surgical risk? So it includes superior surgical intraoperative visualization using microscopy, endoscopy, or combined endoscopy and microscopy, as well as exoscopy, as we can see in this diagram on the upper side here. Another strategy that we have is intraoperative neuromonitoring. So basically, intraoperatively, we are monitoring the integrity of the white matter fibers to prevent any injury. Okay, another strategy that we have is what we call intraoperative neuronavigation. Here using brain-led curve neuronavigation. There's many other systems. So basically, this is like an intraoperative compass or GPS that allows us to know where we are precisely in the brain during dissection. Okay, so it can lead to better localization. Okay, and another strategy that we have is the use of intraoperative fluorescence, because when we give a fluorescent agent intraoperatively, we can identify the tumor and ensure complete clearance. Okay, so now moving on to the, just before I finish, moving on to the final question. So is pineal gland really the seat of the soul? So definitely not in a philosophical sense as imagined centuries ago. But perhaps what makes this structure so fascinating is that it lies at the intersection of human consciousness, biology, philosophy, and even human identity. And every surgery in this region reminds us how delicate, how fragile, and how beautiful our human brain is and how precious our life truly is. Okay? So in summary, our talk today moved from talks regarding ancient myth to modern science to modern surgery. We also move from the concept of third eye to the seat of the soul to extra neuroanatomy and applied this to microsurgical anatomy to achieve precise localization of for excision of this tumor. We also move from talking regarding ancient philosophy to modern patient care and patients' hope of returning to life after getting the disease. So the pineal gland might not be the seat of the soul, but it continues to inspire curiosity, demand respect, and bring to us the meaning of life. And with that, I would like to thank everyone for the opportunity and attention. And if there's any questions, thank you.
Thank you very much, Dr. Lee Kim Peng, for that insightful presentation. With that, I would like to ask if there's any questions from the attendees. If there are no questions, I think it's safe to say that we can conclude today's session. Thank you very much again, Dr. Lee Kim Peng, and the previous presentee as well.